Welcome to UCLA Health's podcast, Medically Speaking. I'm your host, Dr. Eve Glazier. Picture the moment a player goes down in an NBA game. The arena goes quiet, a doctor moves quickly across the court, and in maybe 90 seconds, makes a preliminary judgment about an injury that could define the next 6 months of someone's career. That same doctor, next morning, sees a patient in clinic with a knee that's been aching for 3 months. Nothing dramatic, no crowd watching, maybe someone who's been putting off the appointment because they're not sure it's even bad enough. What I find so interesting is that the medicine isn't that different. Signals are often the same, but what changes is how someone's paying attention to them. Dr. Kristofer Jones is a UCLA Health orthopedic sports medicine surgeon who operates in both of these worlds, sometimes on the same day. He's the head team physician, director of orthopedic surgery for the Los Angeles Lakers, team physician for UCLA Athletics, and a researcher whose work on cartilage restoration has been recognized nationally. He was also, before any of that, a running back, which will come up. Yeah. Today we're going to talk about what sports medicine teaches us, not just about elite athletes, but about anyone who has a body they like to move and wants to keep on using. How to read the signals your body sends before they become a problem, and what recovery really means, and what the rest of us could learn from the way professional athletes treat their own injuries. Dr. Kristofer Jones, welcome to Medically Speaking.
Thank you very much for having me. I appreciate it.
We're so psyched that you're here. You work across such this wide range, NBA players, college athletes, weekend runners, people who haven't even done anything athletic in years, but they might be aching. I'd love to know, what do you enjoy about that range?
It's just like you said, it's the breadth of patients and the challenges, the unique challenges that each patient brings. I mean, everybody, when you're talking about orthopedic surgery and being active and coming into an appointment or coming in for medical knowledge about an orthopedic injury, you're talking about goals, and that's the first thing I ask a patient, okay, your knee pain is debilitating. What are we trying to get you back to, and because everybody's goals are different. Someone may want to get back to running 25 miles a week, whereas somebody else just wants to get back to walking around Disneyland pain-free for 6 hours with their kids, so it's important to not only provide an accurate diagnosis, but then also get a lot of contextual information about what the patient's goals are so you can work together to get them back to that.
But I love that instantly you didn't put one of those goals as bigger than the other.
Yeah, no, they're not, because every person is different and everything holds different importance to every other individual.
I love it. What even brought you to medicine in the first place? You always know you want to be a doctor?
Oh boy, that's a really interesting
Let's just get
story.
Really into it.
Yeah. To be truthfully honest, my dad told me I was going to be a doctor.
No kidding.
And somehow it ended up just coming to be. I mean, I don't know if he saw it as a fit, but he's like, yeah, you're going to be a doctor. And it just planted that seed when I was young. And
I was going to say from as long as you can remember?
Yeah, pretty young. He told my sister she was going to be a lawyer, and she did end up being a lawyer. So maybe he had this Jedi
clearly
type
manifesting for you guys. No, that's great.
Yeah, no, I happen to love science, math, and then you go throughout grade school, high school, college. You figure it out if you really like it. I didn't necessarily know I wanted to go into orthopedic surgery right away. I have a brother who's an anesthesiologist, and he's my big brother, so you always look up to your older siblings, and I thought that may have been a good fit, but just obviously being exposed to orthopedic surgery in medical school and how it tied to a lot of my own personal injuries that I had growing up playing sports. It just always was a natural fit and kept calling me. So, yeah, that's how I ended up in orthopedic surgery.
I love it. And I mean, about you being an athlete, maybe forever, but definitely you played college football, correct?
I did,
At the University of Chicago. Maybe I researched you for a minute. But it is. It could be just this nice biographic detail, but, you mentioned your own injuries. I do want to ask you if having this athlete-centered perspective has influenced how you practice medicine. Not only maybe how you think about, athletics, but how you even think about injury and recovery, and how you communicate about that with your patients.
Yeah, I think me having a lot of firsthand experience with my own orthopedic injuries brings a lot of a great wealth of knowledge of what comes into, you know, the long-term commitment that a recovery really looks like. You know, surgery, if we're talking about something being a surgical problem, is half of it. You know, there is the mental component of getting over an injury, and just like the concept of, you know, somehow your body just failed you, right? So there's getting over that. And then once you have the surgery and you are done dealing with the grind of, let's say, an ACL reconstruction, and you know, the average return to play with sports is usually around like 10 months. So after 10 months of rehab, now it's, again, going back to the mental part of it, it's learning how to trust your body again, because you just had such a major injury that changed your life for almost a full year. So, you know, I've had my own injuries. I broke my right foot playing football. I dislocated my right shoulder playing football, needed surgery on that. I ended up having it my intern year of residency.
Oh, wow.
So that was interesting, trying to get through your intern year, part of it in a sling.
And in your dominant arm?
In my right arm,
oh my gosh.
Yeah. And yeah, I recently, playing pickup basketball, tore my biceps in my left arm about a year ago. Yes. Kept me out of the OR for 3 months, which was not fun. But yeah, like, I'm starting to learn how to really bring that type of experience to how I treat my patients. It was a good reminder at the tender age of 46 to, like, you know, to really bring that perspective home, because, you know, orthopedic surgery is very high volume in our practice, and I think it's easy to, you know, after 15 years of practicing, you know, seeing things consistently day in and day out, to lose that perspective sometimes. So that was an interesting little experience again.
I mean, even the language that you are using with athletes about, you know, right, there's the injury itself, but then there's the mental aspect of my body. You said the words like failed me, for example, or you feel vulnerable.
Yeah.
I mean, that's really strong language to not just use, but to feel internally. So, I mean, how do you kind of talk about that, especially now how you've gone through it at different phases of your own life? I mean, is there a way to kind of maybe reframe that for your patients? Because I would think that feeling failed or feeling extra vulnerable will then influence kind of how you approach recovery. Yeah,
I think that's an important concept, because I do think when when something like that happens, that's kind of where you retreat to. But I think it's also important to remember that on the back end of some of these things, you're actually coming out stronger.
Great.
Let's say, you know, you have you know, a 35-year-old recreational soccer player who just plays on the weekends. They were probably predisposed to that injury because they might have a professional job which requires them to sit behind a desk for 8 hours a day. And the only time they really get to really challenge their body in an athletic way is on a Saturday or a Sunday. And, you know, if you're doing that once a week, your body's not necessarily always prepared for those challenges. And sometimes it's just a mix of, obviously, you know, not being physically ready to play that type of sport once a week, but also a little bit of bad luck. And so, you know, what I tell patients is that, you know, if something like this were to happen and you go through a good year of resetting the body, you're coming out the other end really better for it, right? Because you're fixing a lot of movement deficiencies that you probably had to begin with. You just didn't have the bad luck happen, right?
Right.
And then you're also a lot stronger, you know? Like, I think, you know, sometimes we say, you know, oh, I work out, you know, and I have patients do this all the time. You know, I exercise, I work out, I thought I was fit. And then I send you to a physical therapist who's an orthopedic surgeon's best friend. I mean, I have some great PTs here in the community that I use, and they'll put you through a whole comprehensive movement assessment, and they'll find all these deficiencies, all these, you know, we have so many tools now to really dig deep into how you're moving. And then you point out some of those things to patients, and they feel it now as you pointed it out.
Right.
They weren't feeling it before, but they're like very subtle things. And now you correct those things after an injury, and you're almost trying to make yourself bulletproof, right? And we know the science shows that you need to be strong in certain areas to prevent knee injury. It's the core, it's the hip, it's all these things that have nothing to do with the knee itself, and people don't really know that.
I don't think at all. I mean, I think, right, and then these deficiencies become opportunities.
Yeah.
Right?
Yeah.
So not that we want you to get hurt, but I mean, still, that's a real opportunity.
Yeah, it is. Yeah.
I think there's a lot of, and I'd love to just establish this quickly, because I think there's a lot of, a little bit of confusion about what sports medicine is, you know, and for whom it's for, you know. So when someone says sports medicine doctor, it can mean a few different things. Could you walk us through that, like non-operative versus, you know, someone like you who does operate?
Yeah, I think sports medicine is kind of I think this day and age certainly maybe even be a little bit of a misnomer. You know,
Yeah.
I think I have patients come in and say, "Oh, thank goodness, I'm so glad you're able to see me. I'm not really an athlete," and I say, "Well, I treat way more than athletes.
No, I think that is true.
More
I think that is true. When you even told me the other day about osteoarthritis, I was like, you do wear and tear?" Right.
Yeah. So, I mean, I see patients who have ACL tears, rotator cuff injuries, Achilles tendon tears. They could have been playing a sport, or they could have been trying to change a light bulb, you know, on a ladder in their home, and you know, took a misstep and twisted their knee and torn their ACL. So, you know, you don't necessarily need to be playing a sport to have an injury that a sports medicine doctor actually takes care of. So that's the first thing I would tell patients and you know, people who are looking at wondering what sports medicine is. But it's the treatment of certain types of musculoskeletal injuries that are often seen playing sports. But what I think separates a sports medicine doctor from some maybe more general orthopedic surgeons is we are trained to provide care on the sideline. So we are often at football games, basketball games, soccer games on the sideline, providing real-time care to people who have injuries playing a sport. And that in and of itself is sometimes an art, because you need to make the diagnosis then and there. This is probably an ATFL ligament sprain in the ankle. This is probably an MCL sprain in the knee, and you have to determine based on your exam, you know, the patient's feedback, the athletes, you know, what their symptoms are and how they look as you get them off the sideline, on a table, and back off the table to go through a functional assessment. Can you go back and play? And that's always like,
is that the number one question usually?
Oh yeah.
Wow.
That's the golden question in sports medicine. When can I play?
Right. But even not even just can I play next week, but can I even just go back into the game?
Correct. Yeah.
I mean, that sounds very stressful. Just very high stakes.
Yes.
But you seem cool about it. I mean, you chose to do this.
Yes. You have to instill confidence in the person you're treating.
Yeah.
So
what do you love about it, though? I can tell you love it.
Well, I love sports.
Yeah.
I love being around it. You know, I've played football, Pop Warner football, from when I was the age of 5 all the way up and through college.
Yeah.
And what was cool too is, you know, look, I think someone told me a long time ago, you know, in order to continue to be around this, you don't necessarily need to be an athlete. There's so many other ways to be involved in sports, and this was my path. Yeah.
Well, you're an athlete. Remember that pickup game where you tore your biceps?
Exactly where
kicked too soon?
People ask, how did you tear your biceps playing basketball?
But I really appreciate you breaking this down, because I do think that a lot of people do think that sports medicine is like this VIP service for people who run marathons. And what you're saying is that no, it's about all of our musculoskeletal function. For our listeners, that's your bones, your muscles, tendons, ligaments, and that function, as you mentioned, with kind of goals, matters to everyone. So it's not just like returning to life. Not just return to play, it's return to life.
Right, exactly.
I would love then to know from you, like, let's move on to injuries that we do all kind of deal with. I know you do a lot of, you do all joints, but we kind of talked a little bit about the knee, so maybe we could even just start there. Why is the knee kind of a place where things tend to go wrong?
It's a common injury. It's a very vulnerable joint when you're talking about certain sports. I'd say the number one injury that I see in my practice has to do with the meniscus, a lot of meniscus tears. a lot of cartilage injuries. So cartilage specifically referring to articular cartilage, that is the surface of the bone that is made up of certain type of material that makes the bones frictionless, right? Allows the bones to glide across one another very smoothly. And they're like treads on a tire, and it can wear down with a lot of miles being put on the body playing different sports and just going through life.
And does your research, because I know you do some research on joint preservation, is it about all the joints or also mostly specifically the knee? Mostly
the knee. Yeah. I would say in terms of cartilage transplantation right now in 2026, the majority of FDA approved clinical techniques, surgical techniques that we have are in the knee and the ankle.
Interesting. Mm-hmm. Okay. And then speaking of other joints, though, shoulder, elbow, I think we hear about these things, again, like you're saying, not just in athletes, but any of us who move around. What are these sort of mechanics of why these are trouble spots?
Well, they are the ones that see the most stress depending upon what the sport is. So, for upper extremity sports that are dominant, like volleyball, baseball, softball, all the action is at the upper extremity. We tend to see more overuse injuries now, and I think we'll get into this with some of the issues with youth sports specialization.
Yes, for sure, yeah.
But yeah, it's where you see injuries are very dependent upon what type of sport you're playing and what the predominant joint is that's involved.
Yeah, that would make sense. And I think, and maybe even, with your own experience, sometimes I think it's really confusing as a person, as someone moving around, making the distinction between soreness and injury. And I know it's kind of hard to just completely generalize, but I think people live a little bit at the extremes of it, right? Either they ignore something for 3 years or they have one sort of bad workout and then they think they've, completely destroyed their tendons. Yep. Is there a general way to sort of tease out or think about ordinary soreness versus something that warrants attention?
Yeah. I think number one, you want to look at the consistency of that soreness and what brings it on. If it is let's just say you're a swimmer, right? And you keep swimming in a way that is irritating the shoulder and you have developed now biceps tendonitis. Mm-hmm. If it consistently localizes to the biceps tendon and it doesn't get better with usual things that people recognize, right? Like, oh man, my shoulder is really bugging me. I'm going to back down on my mileage, or I'm going to stop swimming altogether for a week and see if it gets better. You want to see if a brief period of rest tends to make that soreness go away. And if it does, then there's your cue, right? You figured it out that the tendon is the problem. Mm-hmm. The issue then comes in is, all right, if I get back to swimming now and it comes back, what do I do? Well, that probably has more to do now with mechanics, right? You are using your shoulder in a way that's not optimal for swimming, right? And it could be some compensatory problem that you've developed usually at the shoulder blade or something about the way that your stroke has now changed that is now predisposing your biceps tendon to get inflamed. And so I think when you see the pain become more consistent, it doesn't completely go away with a brief period of rest, maybe anti-inflammatories if it's really bad and bothering you during the day. I think that's a sign that you can, bring it up to a physician and go see somebody. Other issues, swelling, right? That's a huge red flag that something is going on around the joint.
Swelling?
Persistent swelling. You tend to see that more in joints like the knee and the ankle.
Yes, for sure.
It's a feeling of pressure, pain that obviously won't subside because you're holding a little bit too much fluid in the actual joint itself. And the problem there is that once the body starts to feel that pressure around a certain joint, the muscles around that joint tend to shut down. So what we will often see is, someone coming in with knee pain and swelling, and the quad muscle shuts down. Then they start to complain of instability. They come in and they say, "Doc, my knee is unstable." You have to tease that out, but you realize, oh, your knee is swollen, right? Like if I were to put a needle into this knee and drain the fluid, I might get 20, 30 cc's out of this knee. Obviously, you have to find out what the source is. The swelling is a symptom of it. But when that happens, your brain tells your quad muscle, don't fire, don't activate, because when you do, you increase that pressure in the joint.
Right.
And so as you're walking throughout the day on a swollen knee, your knee will occasionally give out because your quad doesn't fire appropriately when you're walking. And so now you've got it can be a little confusing to somebody because they're saying their knee is unstable. Well, is it a ligament problem? Well, no, it's more dynamic stability, which is provided by muscles, and static stability is more from the ligaments. So
it's a crazy cascade effect, though, too.
You've got to tease it out.
Yeah. Okay, remind me why I ask patients when they come in with a musculoskeletal complaint, why do I ask them if it hurts at night and it wakes them up?
Well, I think...
I'm like, why have I been asking that all these years?
Yeah, well... So the reason I think that is because you tend to be less distracted by, the busyness of the day at night. You're laying down in a dark room. The adrenaline of the day, of the stressful day, is no longer there. And all of a sudden, you notice your knee is throbbing. Your shoulder is throbbing. Night pain tends to be associated with rotator cuff injuries.
Interesting.
Classically.
Okay.
And obviously, I anecdotally, I think that's why we.
I've only waited like 20 years to ask this, so thanks. I appreciate that. But I do. I think making it really practical though for our patients. I think that right. What I love hearing you say is like, don't rub dirt in it, right? Like go and get it checked out, because especially if over time it keeps on hurting or isn't getting better, there's all this kind of collateral. Damage, I'm just going to say. Right? Or can be.
It can be, and then it's harder to fix.
Yes.
Right? Because now you've adopted all these poor movement mechanics to compensate for knee pain, and not uncommon for them to come in at one point and start to say, well, now it's affecting my hip, now it's affecting my lower back. They're all links in what we call the kinetic chain, and movement at one, certainly affects how the other joint is moving. So.
Okay, wait, that's going to be our title, the kinetic chain. I love it. Let's make sure we give Dr. Jones credit. Okay, I love it. So it's also too, then hearing what you say is that it's not just that something hurts, but also is, how is it affecting my functioning is probably a good thing to keep track of. Okay, excellent. So, but you mentioned swelling. Just to get super practical, I wouldn't mind just sort of saying like red flags, right? You have an injury, again, whether it's sort of acute, happening suddenly, or chronic. These are all such medical words. So we said swelling. I'm going to throw out one. If you hear a pop or a snap, don't wait at home. Yeah.
If you hear a pop or a snap around a joint and it's something acute and there is immediate pain associated with that incident, then yes, that's an acute injury that should be evaluated pretty quickly. The other issue, that we have is that, sometimes patients come in and they say they felt a pop or a click or a snap, but they had no pain, right? So now what is that? Well, it's not uncommon for tendons to pop across or pop over a bony prominence, right? If you had your shoulder in a weird position going to lift a bowl out of a cabinet or something like that, and you felt a pop. You felt it, not necessarily a significant amount of pain, and you notice throughout the rest of the day it's not really bothering you. That's not necessarily that type of red flag. And it's not hanging weirdly
at your side.
Yeah. You can still... It's still located, yes.
And it's
still
not dislocated. Yes. Just want to make sure. Maybe saw Lethal Weapon too many times. I saw that spark of recognition when he pops his shoulder back.
That was me. I dislocated my right shoulder probably 20 times before I got it fixed. Yes.
But then if you're in a straitjacket, you can get out of it like he did underwater.
Yeah.
Right? We have video of you doing that, I'm sure.
No, that was in a movie too, wasn't it?
That was like the third one. Oh my, I'm really dating myself. Okay. I hear Andrew laughing back there too, maybe. Okay. Pop or snap, instability, right?
Instability,
If something feels unstable. Although that's such a doctor word. I feel like as a regular person, what do people actually say to you?
They will say unstable.
Uh-huh.
It feels unstable. Like it feels like it's going to give out.
Yeah.
It feels loose.
Feels loose. Okay.
Yeah. Those are the words they most commonly use.
Difficulty bearing weight.
Yeah.
All these things. Get yourself in to be examined.
Get yourself in to be examined. If sometimes you can fall off a stair, take a misstep, and you jam your knee or you jam your ankle, and you may not have damaged like a soft tissue structure, but the bones can hit one another in a way that you cause the bone bruise.
Ouch.
Right?
Yeah.
And it's good to know that if something is not improving over the course of a couple days with the things we talked about, the simple stuff.
Right. Okay. No, I think this is great.
Yeah.
And I think, going upstream of this is obviously prevention, right? I mean, and I think it's, you mentioned even just going, if you do have an injury and you go through, obviously whether it's surgery or a PT or both, how much you learn, and there's an opportunity to learn a lot about your body. But I do think there's the avoiding injury aspect, right? How do you think about, I guess, that? And I mean, the words that come up in the sports medicine land are things like load, you know what I mean, and gradual progression, but any kind of words of wisdom for kind of preventing injuries? I mean, you also mentioned, too, the person who's sitting at a desk, right, 7 days a week and then decides to go out, but any other kind of big lessons for us?
Yeah, I think in terms of injury prevention, you want to make sure that you are engaging in activities that your body is ready for. So I think the classic example that I see in my office in someone who has some sort of joint pain is they have had some sort of new renewal and commitment to exercise, right? And everybody is, so keen to see results so quickly, right? And if you haven't run in over 5 years, don't start running as your primary form of exercise. I think it's really good to get a little bit of a running start, that to use this
pun intended.
Yes. Hop on a bike.
Right.
Hop on an elliptical. Get the fitness back. Start with something that's low load, not a lot of impact on the joints, and then work your way up to running. Because running is one of those activities that has the most impact on the lower extremity in terms of just like joint load.
Yeah.
And I see it all the time where, your mechanics are off. You are not strong enough in certain areas to really be supporting that load. And it's inevitable that you end up in a doctor's office because you may not sustain like a huge catastrophic injury that results in some sort of surgical procedure. But what we commonly see is something like tendonitis.
Right.
They come in and, their quad wasn't strong enough to begin running, and now the front of their knee hurts.
Right. And then you're really not going to be running for a while.
That's right, yeah.
I pretended like I knew what load meant, but do you mind explaining it?
Load means, it's kind of like a catch-all term, but load management for, say, in the NBA, and that's my world in terms of how we look at load. But it's like it's a measure of stress and strain on the body.
All right. Makes perfect sense. No, that's super helpful. And then, I'd love to know what you think about then cross-training. I mean, you said even with running, start cycling first, right? Or elliptical.
Yeah.
Why is it so important?
Cross-training?
Yeah.
Because you are varying the loads on the body.
Okay. See, now we all know what load means.
Yeah. Yeah. You're varying the amount of stress and strain on certain joints. So, again, if you had a patient or an athlete with a significant amount of pain in, let's just use the knee again for it as an example, and their lifelong commitment to exercise has always been running, and you diagnose them with osteoarthritis. Let's just say they're 45 years old. They've been running their entire life, but now they're starting to develop some loss of cartilage in the knee joint, some loss of shock absorption in the knee joint that's now causing pain. The best thing that you can really do in that situation is try and convince that patient that you don't necessarily need to stop running. We need to work on what the issues are now that have come up that have caused pain to now start to develop. It could be an issue with your mechanics. It could be an issue with muscle deficiencies, strength deficiencies. Correct those. And then if the problem is now solved and you're able to get back to running, perfect. I'll let you run as much as you want to.
Right.
I have no problems with that.
Sure.
Just because you have osteoarthritis doesn't necessarily mean you need to stop running.
Yeah.
That osteoarthritis has probably been present years before you ever came to see me, right? But if we correct those deficiencies and we're seeing that you're still having pain getting back to running, then we have to make some modifications to the way that you train. We back down on the mileage, right? If you're running 30 miles a week, let's take it to 15. Okay, well, now what do we do with those other, the other days where you're not running? Well, we vary the load, the stress and the strain on that particular joint. I try and convince people to go swim, hop on a Peloton, use a ski erg, right? Have you ever seen one of those?
No.
So a ski erg is it's an upright machine. They have them in the gyms now, and they have ropes with handles attached to the top of the machine, and it's like you're cross-country skiing.
Oh, wow.
And you can dial in the resistance to make it easier or harder.
Yeah.
But there's no load on the lower extremity.
Oh, very cool.
Rowing. There's so many
ways to move your body and strengthen. So do you, when people come in though, are you the one as the orthopedic surgeon, sports medicine doc coming up with this regimen? You mentioned but maybe in conjunction with trainers and physical therapists? Is that
exactly.
Okay, that's the approach?
It is a team-based approach. That's right. Exactly.
That's very cool.
Yeah.
Well, speaking of, I think, load, and I think this very modern pattern of overdoing it, I'm just going to say, or having this kind of monolithic kind of types of activity. I really would love to talk about youth sports. I think this is a huge area of discussion, and I think it's so important. I think not just parents, but I think youths themselves, who listen, would love to hear some specifics from you. Again, to date myself, which I don't mind, I felt like when I was in high school, people played sports, right? But then they played the next seasonal sport. Yeah. Now everything feels very year-round. We've completely normalized it. There's a lot of club sports, early specialization,
Yep.
A lot of these very, very high training loads. What are you actually seeing come into your office? And then, of course, I'd love to know what you're actually thinking about it and recommending.
Yeah, at the youth level, I think this problem is being driven by the big machine.
Yeah.
This is a $1 billion industry.
Sure. When
you're talking about youth sports. You have so many stakeholders. You have, the founders of some of these, AAU teams and club and travel teams, and the directors and the coaches and the trainers and the personal trainers outside of the teams.
It's huge business.
It's big business, right? And it's being driven by a lot of the dollar signs. And I think what we have really fallen into is this trap that if we don't participate in this, our kids are falling behind.
Right. And they won't get into college.
Right. Well,
right?
There's so many other ways to get into college.
No, but you know what I mean? I think, but with kids who have real talent, right?
Yeah. No, I think...
And we've fallen behind, though.
But you're falling... Yeah, that's the concern. It's like, you see somebody who is, training... Maybe their team practices twice a week, but you hear the next kid is, he's training 3 times out with a personal trainer outside of that, and you fall into this trap to think that your kid is falling behind. The problem with specialization in a specific sport at such a young age is that you are now introducing the body to this stress and strain repeatedly, day in and day out, over the course of years, to the point where you are now subjecting that joint to early degeneration, right? The biggest example that we have is elbow injuries in youth sports, in youth baseball. When you think about it, Tommy John surgery, you've probably heard of, it was designed by Frank Jobe in the 1970s to salvage Tommy John's career in his late 30s. We are now seeing kids require Tommy John surgery at the age of 16, and sometimes then another Tommy John surgery in their early 20s if they make it to, say, the college or early pro level. My jaw is dropping, but my question for you is is that being normalized then? It is now normalized, yes. Yeah. And, it's almost to the detriment of our specialty that we have now gotten pretty good at doing that surgery. We've perfected it to the point where if a athlete has it, 80% of them are getting back to pitching at their prior level. whether that's high school, collegiate, or pro.
Right. So there's no incentive. There's right to not specialize.
Yeah, I think. Yeah, that
right?
message
I mean, in a way,
can
it's
be
like
lost.
a perverse incentive to be
That's
like, yeah,
right.
well, whatever. There's a great surgery out there, and there's great surgeons.
That's right, and it can be fixed.
Right.
But the message would be, look, I can only do this so many times, because every time you do it, the chances of getting back decrease significantly. So it's up to the doctors. It's up to, and we are really getting on board with a lot of the trainers, and like I said, this is sort of like a team-based approach, to let people know that it's not necessarily the best thing for these kids to be subjecting their bodies to this type of load.
Right. I mean, any surgery is surgery, by the way, too, even apart from the load, right?
Yep. And if you look at the data, it's pretty compelling. You know, if you look at the people who play collegiate sports, there are studies out there that showed that the ones that actually make it to these higher levels, the collegiate and the professional level, they actually played multiple sports growing up. And that is because they're not being weeded out, right, by injury, number one. But even prior to that is burnout.
I was going to say, what about mentally?
Yeah,
I mean,
burnout is huge. 70% of these kids that specialize, they'll be done playing that sport by the age of 13, and that's crazy.
That's a real loss of joy.
That's the middle school level, right? That's
at
middle,
13.
13, yeah. So I think that's another way to approach it too, and you can see it in the kids. They'll. Sometimes you see them in the office with the parents, and the parents are way more involved about return to play, and like kids kind of just sitting there and maybe not as engaged in the process, and it comes out that maybe he's not really enjoying baseball anymore, or practicing basketball 5 times a week. So it's that's a real problem too.
What do you think we should emphasize then for parents and teachers too, right? Or even, I mean, I get it. There's the big business aspect, which I can't ignore, but I mean, what is the message? I mean, do you talk to coaches too?
Yeah. I mean, the message I have is you are a much better athlete if you play multiple sports. And there's this concept of like skill transference, right? So if you play basketball, and then in the wintertime, and where I grew up in Chicago, basketball is a winter sport. You get into spring and you switch to baseball. Now I can learn how to be a better passer in basketball, right? I can throw that long pass cross court, with more velocity, and make that tough pass, as opposed to maybe if I didn't know how to throw a baseball. There's in skill transfer, and it goes between sports. Like for me, again, football, right? Being able to, as a running back, see certain things develop during a play and know where to run and how to, avoid people tackling me. That helps on the basketball court too, right?
Yeah, I mean, I would think that there's vision. Like these like fundamental skills of athleticism, not to mention sportsmanship, right, as well. Yeah,
and you're training your body to also have, again, symmetry, right? Like you want to, in basketball, you want to be coordinated lower body and upper body, right? In baseball, same thing. You want to make sure that you are working on skills that keep the body as athletic as possible from top to bottom. Yeah. That's and that's not always the case with certain sports.
Great. I love to hear the symmetry. I haven't heard that before. Yeah, but that makes tons of sense. Yeah. And you mentioned cartilage, which I think, and thanks for kind of breaking that down. And this is, I think, a lot of, right, you're even working on cartilage transplantation, right? Yep. Which you mentioned, which is super cool. I think that, speaking of something that's just, maybe not misunderstood, I just don't think people talk about it a lot. I think, though, when people hear, like, oh, I have cartilage damage, they're like, it's gone, like the clock is ticking, sort of, my joint is over, I need a replacement. Can you talk a little bit about, like, I would love to do a deep dive on cartilage. Yeah. This is a medical podcast, everybody. What makes cartilage kind of uniquely different, I think, maybe just special to heal?
So the problem with cartilage is it has no blood supply. So when you have a cartilage injury, it is very difficult to get it to heal on its own. When we talk about cartilage injuries, we are usually talking about the absence of cartilage from chronic wear and tear, quote unquote, to a joint. That can come from a number of things, most notably maybe some malalignment of that joint. And it's just, not necessarily a bad thing in terms of just the way that you were made, but it's just the way the big guy made you, right? So layman's terms, knock-kneed, bow leg. Those are referring to whether or not your lower extremities are in mechanical varus, which would be bow leg, or valgus, which is knock-kneed. And if you were to draw a line with somebody who has significant varus or valgus, you draw a line from their hips all the way down to their ankles, that represents something called the mechanical axis. And that shows you how load is transferred from the upper torso to the lower part of the foot and ankle. And if that's the case and you're in varus or valgus, you're now overloading those particular parts of your joints. And so it's not uncommon for someone who is in varus or bow leg to come in with medial meniscus tears, premature cartilage injuries in the medial compartment of the knee where they're now missing some cartilage. And those are huge issues because in young patients, over time, they'll start to cause pain, swelling, loss of range of motion, and then obviously loss of function.
So you really are predisposed to certain, injuries. So when we were kids, or we take our kids into the pediatrician, are they looking at our alignment kind of and sort of saying are you saying listen, you are a little bow-legged, or, you might be predisposed to these kind of injuries or wear or tear over time? Yeah.
So when kids are growing, sometimes they can grow out of it, right? If it's a small amount, but I see this in the female athlete all the time. They tend to be a little bit more valgus. We'll see these lateral meniscus injuries when they come in, and it's important to know and have it on your radar, right? To say, if someone has this mechanical misalignment, and they're complaining of consistent lateral knee pain in the setting of being in valgus, you might have a lower threshold to get an X-ray, to get an MRI, and really dig in to see if there's any structural wear and tear before it became a bigger problem.
Yeah, that's really important to know.
Yeah.
I'm always into awareness. And so then you're also then doing these clinical trials, correct? Involving cartilage transplants. Will you tell us a little bit about them? What it's like to be a patient part of a trial? I think, if you don't mind too, I think we use clinical trials, and it sounds very kind of mysterious and if not intimidating to people. But what kind of trials are you doing? What's kind of on the future?
On the horizon,
the horizon of cartilage.
Yeah. This is the biggest.
It's exciting.
This is the biggest part of orthopedic surgery. I think when I was in training, I think a lot of the research really focused on surgical techniques, how we could get better at reconstructing ligaments, repairing tendons, those types of things. Now we are we've really done a better job at being able to restore normal anatomy with our techniques, and now we're focusing more on biology and how we can augment some of the things that we're doing, like repairs of some of these things, and obviously now in my practice more cartilage transplants. Some of the cool things that we're able to do, surface-based cartilage transplantation procedures. So what we will do is something called matrix-associated chondrocyte implantation. That was, back in the early 2000s, a very onerous procedure. It has now become a lot more straightforward and streamlined and easy, and a lot more predictable in terms of clinical outcomes. So how that works is, let's just say you come in and we identify that you have a small little cartilage injury in your knee, behind your kneecap. Very commonplace. You're missing a 15 by 20 millimeter area of cartilage. You have anterior knee pain, front of the knee, whenever you do any sort of activity, run, jump, even climb stairs, okay? I identify that. We go through a whole rehab process, doesn't help. We talk about injections. That's a huge part. Biologic injections.
Yep.
Things like platelet-rich plasma, hyaluronic acid. Those are the gel injections that we use. Those are the two that probably have the most data behind them for knee cartilage injuries. And what I love about them is they're not harmful to the joint. Back in the day, we used to use a lot of steroids. We used to just do repeated steroid injections to a knee. And now we know that, that may provide some short-term temporary pain relief. But the problem is those steroids are actually chondrotoxic, meaning that they're not healthy. They're not really good for the healthy chondrocytes that you have in the knee, and they can cause further joint degeneration if used too liberally. Yeah. So we tend to, in younger patients, veer more towards those biologic options, the PRP, the hyaluronic acid.
So cool.
Bone marrow aspirate concentrate is another one. Doesn't have as much literature behind it, but that one sounds really scary. We take some bone marrow from a bone, usually the pelvis, has the richest source of growth factors and cells. We spin it down in a centrifuge to get an isolate portion of that bone marrow and inject it into a joint. Has a really rich source of something called IL-1 receptor antagonist protein, which is a very potent anti-inflammatory. And so all of this is meant to just calm down inflammation, provide a better mechanical environment. So say, for instance, with gel injections, it provides a little bit more shock absorption to the knee. And just better mechanical environment so that the symptoms are better. And then let's just say those stop working, right?
There's so much, though. This is so cool.
Now we're getting into the cartilage transplant surgery. So what I was saying before, MACI, or matrix-associated chondrocyte implantation. If it's just a cartilage problem, which is surface-based, right, the bone is normal, then I can go in at the time of a first surgery, a knee scope. I harvest some cells, some cartilage cells from a non-weight-bearing area of the knee. Those chondrocytes are then isolated in a lab and expanded and implanted onto a collagen-based scaffold. We then take that scaffold, which gets shipped to us from a lab in Cambridge, Boston, and we implant it into the knee using a fibrin-based glue. Sometimes we need to stitch it into place as well. And over time, that scaffold, the cells from that scaffold will grow new cartilage cells.
That's amazing.
And patients get better. I mean, they pain relief, swelling goes down, and they're able to get back to a lot of things. And there's sometimes still some modification of what you need to do. You know, again, like if you're running 30 miles a week, maybe we need to back that down a little bit. But there are procedures like that have really changed how we're able to manage knee pain.
Yeah. Are you doing this on other joints as well yet? But this
you
is
can
knee.
do it.
Yeah.
You can do it in the ankle as well. FDA approved for that. Yeah.
So so speaking of your very then wide range of patients, how often, I know it's hard to generalize, but how often are you getting to sort of, I mean, you use biologics, platelet-rich plasma a lot, but how often are we getting past that point where you're like, yep, time for cartilage transplant?
When all of the, it's like a stepwise kind of approach when all of those things have failed.
And have you done this with athletes already?
Oh, yeah, absolutely. Yeah.
Your elite athletes,
Yeah. No, we use those types of orthobiologic injections all the time. I mean, to the point where even, they're used preventatively.
Really?
Yeah.
Oh, wow.
Yeah, there's newer research to suggest that some of those injections are chondroprotective, so they can actually protect the joint from future wear and tear. And a lot of these guys, we are treating them in a way to make sure they stay on the court. And if we know you have pre-existing injury, cartilage injury specifically, there is literature to show that if you looked at all the NBA draft combine athletes who go through that whole process of being evaluated for teams for the NBA draft, there's a study out there that shows up to 80% of them have pre-existing cartilage injuries in their knee.
Wow, and is that based on imaging?
That is based on MRI study.
On imaging, okay.
Yeah,
wow.
Yeah. So you can. That's an important message for patients and people too. Is just let's just say you had an injury where you fell, and we're suspecting an MCL injury, and your MRI comes back and it says that you have a cartilage lesion in your knee as well, somewhere unrelated to the medial side of the knee. It's an incidental finding, right? It was not bothering you before. And I always try to, instill confidence in the patient to say, hey, you were coexisting with that injury to begin with. Don't worry about it. It's something we can monitor. If for whatever reason in the future, if you were to develop pain that localizes to that area, then yeah, we can then look at it more closely. But it's common to have these cartilage injuries, quote unquote, and have them be completely asymptomatic.
And it doesn't have to hold you back.
Correct. Yeah.
I would love to talk about rehab too. Then as part of these treatments, because you mentioned when we spoke, but also just even earlier in this conversation about how there's a very team-based approach to orthopedics, right, and sports medicine. Because I think for some people they're like, oh nope, I have a problem, I'm going to do a procedure, and body handles the rest. But that's not how recovery works.
Yeah. No, for me, I have a very good relationship with a number of physical therapists who I know and trust, who go beyond looking at a specific injury and look at how the entire body is playing a role in that left knee pain.
Yes.
There are so many ways to evaluate patients and look at things like limb symmetry index, LSI is what we call it, torque to body weight ratio. Like, do you have enough strength in your legs to support your body frame, right? Like, what a 15-year-old soccer player needs is very different than what a 32-year-old NFL offensive lineman needs. And so there are very science-based numbers and data that we know that support what you need to do what your body is asking you to do.
It's so holistic too. It sounds like just very, very comprehensive.
Yeah.
So there's a huge part of it. Something also, something that you've said to me in the past, which has stuck with me, is that recovery is milestone based, not calendar based.
Absolutely. Yes. I preach that.
Yes. Tell us a little bit about it. That's really stuck with me.
Any athlete or patient wants to know an estimated timeline for returning to their activities. Sometimes these are things that, just keep you sane, being the ability to go to your Orange Theory class or your CrossFit exercise or, playing recreational soccer. What is the estimated time frame to get back from, say, an ACL reconstruction? That's the one we have the most data from. It's about, on average, 10 months. I will tell patients in the office 8 to 12. I give them that wide of a time frame.
Smart.
And it's just because there are so many individual factors that people are coming into that have to be addressed before you meet all the criteria to get back to playing your individual sport. You may have been dealing with knee pain for 2 years prior to having your ACL tear, which in fact may have been why you were predisposed to having your ACL tear, right? And so now we are digging you out of a hole after reconstructing your ACL that was already there for almost 2 years. Whereas somebody who is in prime shape, and let's just say a collegiate athlete, they may have been more on the bad luck side, right? And had someone run into their knee, which caused their ACL to tear. Well, they had no pre-existing strength deficiencies or poor movement mechanics, and so they're coming into that surgery in a little bit better shape than someone who had all these issues prior to it. Yeah. So I preach, it's really important to realize it's a time frame. The way I have it's my PT prescription that I give physical therapists after surgery for an ACL reconstruction is almost 6 pages. And it's a 6-page,
great, though.
And it goes from day 1 post-op to 8 months post-op. It's a roadmap, and it's meant on phases, right? And phase 1, you have to demonstrate that you can safely and effectively do exercises A, B, C, and D before you move on to phase 2. Phase 1 may take you 2 weeks. It may take you 6 weeks. But phase 1 is really setting the foundation for more complex movements in phase 2. And so it's just important to tell patients, hey, you're not behind. You may catch up in phase 3 or 4. And it's just we are setting the stage for future phases so that we know that you can safely get back to doing those particular exercises without causing any undue harm that may make us go backwards.
Right, or anything additional.
And when you explain it that way, they really get it, and they can be a little bit more patient. But it's a wide range.
But I love it. It's focused and bite-sized, and right. It's not probably not even necessarily linear. It's probably
That's
the
right.
The jagged upward trend. Hopefully.
You will always reach a speed bump.
And then in your amazing sort of like map, is there a little bit of like psychology to it too?
Well, there are some studies that have looked at, I mean, there's a psychological readiness scale for returning back to sports after an ACL injury. Yeah. Yeah. And for all of our athletes at UCLA, we use it. Professional athletes as well. You want to know that an athlete is mentally ready to get back to playing sports. So that's a huge part of it. Absolutely.
Is a lot of that dependent on how they feel physically, or is there a whole just other aspect to just that psychological return?
It's a lot. It's really based on like how physically how you feel
and having that confidence to return.
Yeah.
And then kind of get over that feeling of vulnerability.
Yeah.
And failure, which I'm not into.
Yes.
You haven't failed.
Yes.
Speaking of elite athletes, you work in these very high pressure settings. You're that doctor striding across, the court. When an athlete does go down in front of 20,000 people, no pressure, Chris. What are you actually assessing in kind of those first 50, 60 seconds?
Oh, on national TV, right?
On national TV, yeah. You're like, how do I look?
Yeah. You're like, well, you're making sure that it's not an emergent situation.
Yeah.
Before every game, we meet at 35 minutes on the clock, pregame, as a team. So it's comprised of myself, our head team physician for primary care, sports medicine, our dentist, our team ATCs on both sides of the Lakers and whoever we're playing, paramedics. We all meet in a circle. It's probably about 15 people, and we have an emergency action plan. And everybody knows where the AED is. Everybody knows how to signal when someone's on the court and we need the paramedics to come out right away. So we're all on the same page about the efficiency of care, particularly when it's an emergent situation. So I get out there, I run out there, and I'm assessing, what's the problem? Number one, is this a knee injury? Is this a cardiac injury? It could be a number of things. I usually see it, live and in action, but sometimes maybe my visualization may be obscured and I didn't catch it on the Jumbotron. And so I'm really assessing, when player went down, what's the issue and is it emergent? I typically deal most specifically with our musculoskeletal injuries, where we have a whole, medical team who deals more with cardiac injuries, who are there and ready to assess things there too. And from there, it's okay, if this is a knee sprain, let's safely get you off the court. Let's go to the back to the training room and assess it. I'll put patients through a whole physical exam right there in the training room. We'll determine, is this significant to the point where we need to go get an X-ray? We have the ability to get X-rays in our stadium. Am I concerned about a fracture? Am I concerned about some sort of avulsion of some important structure that could show up on an X-ray? And then from there, if we clear the patient after getting an X-ray, and I'm not necessarily concerned about the physical exam and their ability to get back and play safely, not risk any future injury, then we make that decision then and there. But there are often times where, we want to be conservative. It's a little harder in the playoffs. We're approaching playoff time right now, and the stakes are higher, and the competitive juices are even more flowing, and so they want to get back out there. On your part or
the players?
Oh, more theirs. I'm just making sure that they're not going to risk more of a significant injury. That's always my concern.
But do you have moments like that where you're like, listen, you need to stay off, and the player's absolutely not, put me back in?
Yeah, we run into those issues. We're getting to that point in the season where those are more intense conversations, but I'm running into those issues where medically you need to say no, you're out.
Yeah, and you have to just stand your ground.
Yeah.
That sounds rough though. But you're keeping them and the team safe, right? You have that. You're the one that has that perspective.
Yeah.
Okay, just a couple last questions. Thank you for being here. I think a lot of times people often want to know, especially since you watch elite athletes deals with injury and how they deal with recovery. But so I am curious about that. But as we're talking too, I now want to know, how do they feel about performance? Are there lessons from both how they perform, right, and prepare for performance, in addition to how they sort of approach recovery, that there's, something for the rest of us?
Yeah, that's a great question, because I use a lot of my experiences with professional athletes to inform how I counsel and educate my patients in my regular practice. So like I was saying before, it is common to see a 21-year-old NBA athlete with a knee that looks not so great. A lot of that may have to do with sports specialization, right? But that is an NBA player who is coming in after years of playing high school and collegiate basketball with no symptoms whatsoever, and performing at the highest level that we know is possible. So it's easy for me to see this person who is coexisting with all this premature joint wear and tear, and see like what great physical therapy can get them, what low-hanging fruit in terms of like modalities we can use to help symptoms and help them get back to a functional level. And sometimes those modalities, say for instance PEMF and shockwave therapy and all these types of things, we now know through using them in the professional arena that they have some role in making joints feel better and getting back to playing sports. If you use them in the regular setting, I have now been able to now help this person get back faster too, to the point where now they're getting back to Orange Theory and all these things. And
this is great social proof.
I'm teaching them that, like, look, there's so many things that your body has going on right now that you're that's there and you had no idea was there. And I can get this guy back to playing with all this stuff going on. I can get back you back to that kind of stuff as well. So.
I mean, I think it's, first of all, it's like really optimistic, but it's very, very exciting to hear about, because I think the general public, myself included, is sort of like, oh no, I go see my sports medicine doc and then I do PT, and PT is amazing.
Yes.
But you and your colleagues have little by little educated me to say like, no, there's all these biologics, there's these, there's, injections, but now even just that there's this really amazing, research and clinical trials. I mean, that's like really transforming the field itself. Yeah,
and if you ultimately need surgery and all those other things fail. Yeah. But there's so much, I found there's just so much low-hanging fruit, prior to even getting to a point where you need surgery. Oftentimes I'm trying to talk people out of surgery more so. Like they know something's wrong with their body and like it needs to be fixed. Like, no, let me educate you. And I'm talking longer about like why they don't need surgery, to try and convince them that they can buy into these other things that I see work in the professional, athlete. And we can do that with you and get you back as well. We always say trust a surgeon who doesn't first prescribe you surgery. Right? You are so amazing. We're going to have some separate questions, but I do want to close up this part of the conversation. I am so grateful for the conversation. You've just completely not only educated me, but expanded this whole frame of sports medicine, not just being for elite athletes and dramatic injuries, but for those of us who just like to move our bodies and want to age gracefully and enjoy, like being alive. So whether you're competing at this like super high level, whether you're just getting back into exercise or just being strong and functional, your expertise is just so welcome. We're so grateful. Thank you so much for being here. Thank you for having me. Absolutely. And this is Medically Speaking. Thanks for listening. Stay curious, be healthy, and take good care. Chris, you're amazing.